from Johns Hopkins University, an assistant professor, another bio that I will not try to read. Alan is going to give us a more a really interesting academic perspective. I think now that we've had the sort of the overview of the convening mechanism and then the practical application on the ground, and we thought Alan's presentation would help us frame this and ground this. So over to you, Alan.
Tim. And good afternoon, everyone. It's a pleasure to be here this afternoon, despite the tornado watches and brave weather out there, to participate in the discussion on how existing technologies and innovative approaches can potentially help us to improve health where it's needed the most. Today, I hope to explore some of the landscape of maternal and neonatal health priorities, sharing some relevant data for Bangladesh, where our group has been working now for over a decade. And throughout, we'll hopefully see some examples of opportunities and challenges for mHealth in this and similar contexts in resource-limited settings. As we know, the burden of both maternal and neonatal mortality are co-located on two continents, with a proportionately higher concentration on the Indian subcontinent. A significant challenge to reduce these rates in the immediate future is getting the necessary care on time, targeted to where these deaths are taking place. This is true for maternal and neonatal mortality, where the first days and even week remain a period of extreme vulnerability. Across most of South Asia, most deliveries still occur in the home. In our research sites, over 80% of the deliveries that we've seen in the past 10 years have taken place in the home with little to no trained attendants. However, these crisis events do not occur in a vacuum, and there are strong known associations between elevated mortality and maternal characteristics, such as age, parity, nutritional status, etc. Here's some data from a large population cohort we've been working with since 2001, looking at data representing 12,000 live births. Overall neonatal mortality in this group was 57 per 1,000 live births. But you can see a clear association with poor outcomes with younger maternal age, as an example. Furthermore, each of these tragic events, we often see reduced to a group statistic, reflects a complex series of circumstances that have led to that death. So here's an analysis of 250 deaths of women of reproductive age. These are women between the ages of 14 and 45 in rural Bangladesh, and whose deaths were attributed through a verbal autopsy process to chronic conditions. Now, we see how decisions influenced either by a lack of resources, that's to say poverty, or a lack of information, have led to highly convoluted patterns of care seeking, beginning for the most part with traditional healthcare providers as the first line of treatment for most women, and then moving to provider looking for a solution. Now, I want to share with you a typical narrative account of how delayed decision-making compounded by delayed transport can have tragic consequences. Here's the account of a 20-year-old woman who experienced obstructed labor. When I tried to give birth, the umbilical cord came out first. The DAI, or traditional birth attendant, who was helping me, called two other trained DAIs. They were afraid to touch me because they said they had never seen anything like this before. 2 hours later, my family called an ambulance, but the baby was already dead, probably from the cord being wrapped around its neck for a long time. This narrative from a verbal autopsy reads, during the home delivery, the child's head became stuck. An untrained DAI used her fingers to pull the child's head to deliver the baby. The placenta would not come out even after much pulling. The woman had so much bleeding that it flowed over the floor. The family hurriedly took her to the government hospital, where attendants inserted their hands to remove the placenta. The bleeding stopped. The woman became very weak, but doctors were unable to get saline to enter her body. They suggested the woman be transferred to the district hospital, but before the family could arrange transportation, she died. So we talk about shifting the paradigm of care towards a continuum, where each life stage has an impact on the next. These create different paradigms of opportunity to improve maternal and infant health outcomes, from early interventions focusing on improving knowledge, delaying marriage and thus pregnancy, to more immediate interventions ranging from the delivery of antenatal care, immediate emergency obstetric and neonatal care, and to ensure rates of high vaccination coverage and IMCI, the appropriate delivery of IMCI. But mHealth does not have to be complex. The opportunities for mobile phones to act synergistically with existing health systems, as Josh clearly showed, in low to middle income countries are many. In addition to improving access to information and routine preventive care, one of the most critical ways in which phones are being used, even in the absence of formal mHealth systems, is to compress the time between the crisis and care. So to compress the time between crisis and care. So if we revisit this timeline of pregnancy, from the identification of pregnancy to the delivery and immediate postpartum period, there are numerous ways in which mHealth strategies can open up opportunities for intervention. First, if we look at the windows of opportunity, here are a few ones that traditionally intensive community health worker programs have been needed to identify, register, and counsel pregnant women. As Tim pointed out earlier, the simple act of documenting pregnancies and outcomes in these communities is among the most important obstacles we face in understanding the magnitude of the problems and in calculating program impact. Next, we have windows of extreme vulnerability, periods in this pregnancy continuum where risks are high and without immediate appropriate responses where the crises are occurring, it's difficult to expect to save lives. The mHealth innovations, of which these are a sampling, offer a potentially wide range of solutions that could provide the health systems and its workers access to these critical windows of opportunity during pregnancy. So in today's talk, I'll be drawing on data generated from one of our flagship research sites in South Asia, the Jovita Population Research Site in northwest rural Bangladesh, shown here in red. This area represents a typical agrarian population of the Gangetic floodplain of South Asia. Covering a size of over 4 times Washington, D.C., we set up this site in 2001 working with the Bangladesh Government Ministry of Health and Family Welfare, supported by USAID and the Bill and Melinda Gates Foundation. A staff of 850, comprised mainly of community health volunteers, conducts pregnancy and birth surveillance, enrolling on average 300 new pregnancies every week. 3 large randomized control trials to explore specific interventions to reduce neonatal and maternal mortality have been conducted in this site, enrolling to date almost 100,000 pregnancies from whom we have learned. Enrolled mothers are periodically interviewed for diet, morbidity, and other interesting facets of their health and their infant's health. Pregnancies are monitored weekly, and vital events reporting is ongoing using both paper and digital systems. Field-based study workers on bicycles reach newborns within 18 hours after birth on average. So this system generates volumes of data on each woman's pregnancy, reproductive history, health, and infant outcomes. This area is now among the most exquisitely mapped of South Asia, allowing us not only to enroll and track research participants over time, but to also use innovative evaluation techniques, such as distance to facility, healthcare provider catchment area, and treatment-seeking behaviors to evaluate interventions. So let's look briefly at some of the findings from this population. We see early marriage is still extremely common, and that women become pregnant soon after marriage. If we think that girls are getting married on average at age 16 and a half, half of them within 13 months are pregnant. So these are young women becoming pregnant while they themselves are still growing. Infants are born small and vulnerable to a wide range of exposures. Our median birth weight in this population was less than 2,500 grams. Many of these babies are born before they're ready for the challenging environment that awaits them outside the womb. And a health system that, despite much progress in recent decades, continues to struggle to deliver standard preventive care to the majority of its rural population. This first red bar, I'll point out, means 0 antenatal visits. That's 76% of this population. So what have we seen with mobile phones? Well, like we've seen elsewhere in South Asia and Africa, as David pointed out earlier, penetration of cell phones is high, as seen in the cell tower location map at the right. And even in this resource-poor rural community, ownership of phones has been steadily increasing. However, it's important to note that this does not necessarily mean that pregnant women have phones, nor, as others have shown, access to the phones, given to the strong male-dominated culture in many of these South Asian populations. Now, even more interesting is some preliminary data that suggests, even in the absence of a formal mHealth system, cell phones serve as a critical link in times of crisis. We did an interim analysis of almost 12,000 pregnancies recently in the past 3 years, looking at near-miss events. So near-miss events are near-death experiences in women's reproductive history. And 5% of women in this 12,000 pregnancy cohort experienced what they judged to be a near-miss event. Half of these women reported using a mobile phone during that crisis for a range of activities, ranging from calling a provider to their home to asking for financial aid to assist with the care. Here are some examples which demonstrate ways in which mobile served as critical links to, again, compress that time between the crisis and care. A 23-year-old woman who experienced obstructed labor says, when the traditional birth attendants realized they could not handle the delivery, they phoned the family welfare assistant for advice. She told us to go straight to the government hospital where I received an emergency C-section that saved me. Another narrative from a 17-year-old woman who experienced PPH says that after delivery, I lost so much blood that the village doctor could not make it stop. He used his mobile phone to call an ambulance to immediately take me to the Maternal and Child Welfare Center. So again, anecdotal evidence, but still interesting examples. But one of the major challenges in resource-limited settings is what I would call the equity gap between the population that bears the highest levels of morbidity and mortality and the population that has access to mobile phones and can afford the downstream services. Here we see how, as I showed you a few slides ago, there's a clear temporal trend of increasing phone ownership in rural families. However, there remains an important gap in ownership of phones in any given year between high SES, shown in green, and low SES, shown in red. And this gap persists very clearly over time. Now, why is this important? Because as epidemiologists, we always have to consider confounding. When we see a success story about cell phones and health, we have to ask ourselves, are there other factors that are involved in that association that we're seeing? So looking at neonatal mortality in the same population over the past 6 years, we see, thankfully, declining trends in neonatal mortality in both the high SES and low SES subgroups. This time the green, high SES, are on the bottom as they experience overall lower neonatal mortality, but a similar gap exists over time, persisting, stressing the importance here of addressing equity and access to phones when evaluating the impact or success of mHealth interventions. Now, we also examined whether the speed of birth notification. In this study site, we've set up a very extensive birth notification system because it's important for us to get to the births soon after they occur to collect data on that delivery. And we examined whether the speed of birth notification differed by whether the family owned a mobile phone, here shown in blue, versus not owning a mobile phone, here shown in red. And we found that over the most recent study period, since 2007, ownership of a phone in the family did not change the distribution of time to birth notification. So the distribution of these two histograms is almost identical. And this suggests either A, that traditional notification systems work well, or perhaps that household phone ownership is not necessary for rapid access to phones in the community. So, where does this leave us? Well, as you've probably heard epidemiologists say before, we need more data. And we don't have the answers for what works with mHealth at the moment. But we can focus on quantitative demonstrations of impact of mHealth technologies that will play a critical role in mobilizing resources to effect program and policy level changes, to influence stakeholders, and we can focus on delivering evidence-based MNCH interventions through the vehicle of mobile technologies, while we work on developing new opportunities that mobile phones give us access to, which we didn't have access to before. To move forward, we need to work on developing a common mHealth vocabulary. We need a clear set of research priorities and definitions of success that are driven by data. And we have to agree on ways to prioritize our efforts and spur the donor community to support these prioritized efforts. Now, in public health, we like to put things into diagrams, and here's a nice three-dimensional perspective on finding the target space. For each setting in which we think of an mHealth application, it's important to understand the context on a number of axes, X, Y, Z, and even axes that I haven't been able to display on this graph, to see whether the mHealth intervention will be a good fit for that population that we're targeting. And the continuum is not only the continuum of pregnancy, but a continuum of technology, a continuum of financial capacity, and a continuum of coverage within that population. There's also existing health system infrastructure, burden of disease, mortality, etc., that have to be considered. So in conclusion, ICT and mHealth solutions have tremendous promise to improve maternal and infant health in resource-limited settings. However, it's important to not let the technology drive the public health agenda. The priorities for maternal and child health are clear. What's needed is an understanding of how these tools can most effectively strengthen or enhance health systems in settings that need immediate stopgap or long-term infrastructural solutions to prevent maternal and neonatal deaths. Thank you.